Well, it's my distinct pleasure to introduce our keynote speaker. And I have to say, when we were putting this together, I really couldn't think of another person who would do the job that Dr. Effinger is going to do for us, as far as seeing the big picture, helping us think about survivorship care at that 30,000-foot level, and then think about the components, helping us zoom out with all of that. And when we had talked about this, we didn't realize it was going to compete with a very important meeting that he's at in California today. And so he's being a very good sport, being up to do a 6 a.m. keynote. But he's going to do that, and it's going to be interactive with our Mentimeter questions and what have you. And so I really appreciate his willingness to step forward and do that despite the conflicts in geographic location. He's going to be with us anyway. And so I just want to give you a brief bio on him and then give this time to him to talk to us about all of this, is that Kevin Effinger got his MD at UT in San Antonio, and then he did his internship, residency, and fellowship at Baylor. And I must say it's in Waco. So those of you who are HGTV Fixer-Upper fans, that was before that made the town cool. And then did some training here at NCI in a number of areas, did advanced research training in epigenetics and radiation epidemiology as well. But we all know him as being a champion of survivorship at every level, and particularly interested in the role of the primary care provider in providing survivorship care. He's currently a family physician at Duke, as well as the director for Oncoprimary Care and director at the Duke Cancer Institute Supportive Care and Survivorship Center. And believe it or not, we actually collaborate, the light blues and the dark blues, except during basketball season. But now that doesn't matter for either of us. I think we're in good shape again. So thank you, Kevin, very much for joining us, and we'll leave it to you.
Great, thank you so much, Deb, and it's great to be with the group. Jennifer, I'm going to see, do I have control now? We had handed over control a moment ago.
Yes, you should have control of the presentation.
It's not advancing right now for me. Oh, now it does, maybe, no. Pardon everybody, we had this worked out a few minutes ago. Oh, here we go, good. Great, wonderful. Thank you so much, Deb, and I appreciate it. And just an applause to Deb for all of the hard work that she has been doing in her role as interim director for NCI's Office of Cancer Survivorship. It's fun to look around the room as Bob was talking and see all the familiar faces. I don't know if I saw Julia there, but thanks so much to Julia Rowland for the legacy that she has established through the office. The planning committee, I saw you all stand up, and thank you so much for your tireless work. And most importantly, thanks to our NCI staff, to Bob Croyle, to Paul Jacobson, and all. We owe much to you. And as Deb said, I'm in sunny San Diego, and I really do wish I was there. It's a lot of fun, and the agenda looks great. So Deb's charge to me was the following. She said, where do we need to put our efforts to move the field forward? Does survivorship care need to be distinctively different from follow-up care? How do we change the culture to integrate survivorship care into practice? Do we need to conduct multi-level interventions to move the field forward, and then be provocative? And hopefully I'll be able to answer some of these issues through my talk, and then throughout the day you will be dealing with these. I'm going to give you the answers to the questions from my perspective that I'll be asking. Number 1, wow. 2, top down or sideways. 3, gulp. 4, not a bad idea. And 5, let's go. This is a slide or a graphic that many of you are familiar with. This is the NCI's Cancer Control Continuum that shows going from etiology to prevention, detection, diagnosis, treatment, and survivorship. And indeed, today you're focused on survivorship, and you're looking at the cross-cutting areas that include communication, surveillance, etc. We've been thinking a lot about this with our cancer survivors and realizing that 1 out of every 5 new incident cancers is a second cancer. And so we think of it almost as a circle rather than linear, where our patients come into cancer prevention, they go through screening, detection, cancer therapy. Here's the area that we're focused on today, survivorship or chronic cancer care, and they have the ability then to have cancer prevention for second cancers and on through, or even our late effect screening, or in some of our population go on to end-of-life care. And in each one of these areas, there's an area that the oncologist and the primary care physician can work to improve outcomes and improve our value-based care. So if I go back to the seminal 2005 Institute of Medicine report, From Cancer Patient to Cancer Survivor, Lost in Transition, you remember the first box showing the essential components of survivorship care: prevention, surveillance, intervention, and coordination. And one of the key recommendations, the number 10 recommendation in that seminal report, was NCI and others should increase their support of survivorship research. New research initiatives focused on cancer patient follow-up are urgently needed to guide effective survivorship care. So our first question is NCI survivorship research funding 0, not as much as we would like? 1, or the next question, next answer, pretty good, but could be better, or the next response, wow. Give people a moment. Let me activate that. Great to see the responses. And you see that most people are putting in there pretty good, but could be better. And of course, Kevin, the eternal optimist, says, wow. And this is why I say wow. We did a pen and pencil effort of looking at grants that were new grants in each of these years, according to whether they were R01 observational or intervention studies, R21s, or K awards. And what you see is, from 2008, recognizing that was the time period where we were starting into a recession, but nevertheless, from 2008 to 2018, you see a very substantial increase in our R01s, both observation and intervention, but especially intervention. Concurrently, we also saw an increase in our K awards, almost more than doubling the number of our K awardees over this time period. So with this rich research that has been funded by NCI and by others at NIH, are we disseminating our findings? Since the 2005 Institute of Medicine report, there have been 2,682 PubMed citations dealing with psychosocial and physical late effects, subsequent malignancies, lifestyle behaviors, biologic mechanisms and pathways, and the growing research area looking at multiple interactions between our lifestyle behaviors and cancer therapy, or comorbidities in cancer therapy, or gene and cancer therapy. So let me give you 3 examples of that latter part. This is one of the elegant studies I always like to look back to that Lois Travis led when she was at the NCI, working with a population-based cohort of Hodgkin lymphoma survivors. And she looked at the likelihood of having lung cancer depending on whether or not they had chest radiation, alkylators, or they were smokers. And she separated the smokers into non and light smokers, into moderate and heavy smokers. And so neither an alkylator or chest radiation, no chest radiation, an alkylator, chest radiation, no alkylator, or the combination of both, depending upon whether or not they were a smoker. And what you saw is that with our non and light smokers, there was a slow increased risk of lung cancer for these combination of therapies. But if instead you looked at those that were smokers in combination of their therapy, and then especially if you had both chest radiation and an alkylator and were a smoker, you see an exponential or a multiplicative model of risk. Work from Smita Bhatia and her group looking at cumulative anthracycline exposure and the risk of heart failure. And what they identified was a gene therapy interaction, where there's a specific variant that they were looking at here, CBR3, that if you carried the mutant type, even with low doses of anthracyclines, you were at an elevated risk of having heart failure. As an example of looking at comorbidity interactions with cancer therapy, this is work by Greg Armstrong from the Childhood Cancer Survivor Study, where he looked at the risk of coronary artery disease, major events, myocardial infarctions, or death from an MI with an interaction between chest radiation and cardiovascular risk factors. So if the patient had 2 or more risk factors, you see that elevated risk. If they had chest radiation at any dose, you see that elevated risk. But when you had both of those, you again have a near multiplicative model where there's an interaction between the chest radiation and the cardiovascular risk factors. So much has been done in that area, and hopefully over the next 5 years, what we will see is a growth in our understanding of what leads to the late effects that we see in our patients, both those psychosocial as well as physical, and extend our look at interactions. What about randomized interventions? Well, since the 2005 IOM report, we were able to identify the following published randomized clinical trials: symptom management, looking at fatigue or pain or neuropathy, lifestyle modifications, big area here of physical activity, but even in diet, and smoking cessation or smoking avoidance. Survivorship care plans, 15, but a fairly small number of intervention trials looking at reducing the morbidity or risk of having a physical late effect. Encouraging, there's a number of studies, oh, it went too fast, number of studies that are looking, that are in the design phase that are reported. So let's talk about survivorship care plans. Back to the IOM 2005 report, recommendation 2 said patients completing primary treatment should be provided a survivorship care plan. And then recently we had a long-term survivorship care after cancer treatment workshop where the keynote on that said, progress, limited evidence for altering or improving care. A really nice paper that Paul Jacobson, Deb Mayer, and others were involved in that was a systematic review of the impact of cancer survivorship care plans on health outcomes and healthcare delivery. And what they concluded is that there is little evidence that survivorship care plans improve health outcomes, and is need to evaluate ways to ensure that survivorship care plans recommendations are subsequently acted upon as part of an ongoing care. It's not simply handing the document, but it's actually the process of care. So what is the goal of a survivorship care plan? Let me first start by saying I am a big fan of survivorship care plans, largely for oncology records. If the patient has a recurrence, we need a good, clean record of what happened. If they transfer to another center, we need a good, clean record of what happened. But I think that as we look at this, survivorship care plans are likely too oncocentric, even with the wonderful work that Deb Mayer did in taking that monstrous document, survivorship care plan, and paring it down to a 2-pager with ASCO. If you look at the items, most of them are oncocentric, and they're what we need to know at the cancer center, but not from the primary care provider's perspective. Our second question, if we started from scratch, how would we develop a document to be used by a primary care provider? A top-down effort using our oncologic jargon. B, bottom-up, tell PCPs to draft it. Or C, sideways, let's collaborate to make a PCP-facing document that includes what we need to communicate. So let me activate the Mentimeter again. If we started from scratch, how would we develop a document to be used by a primary care provider? You guys are making me very happy. And Trish, I loved your directions at the start regarding jargon. So let me move forward and talk a little bit more about survivorship care plans and the elephant in the room. Sorry, I'm getting a Trish, somehow we move forward. There we go. For some reason, I'm just getting a partial screen on this, but nevertheless, let me read out the question. The number of cancer survivors in an active cancer center. Give us an idea of the numbers. I'll activate that again. One response says, I'm not sure. Next response is just the right amount. Next response is too few. And the next response is gulp. Let me open voting. Great seeing these responses. So I'm going to move on to the next slide. We spent a bit of time looking at Duke at our numbers and trying to understand where we would be going over the next 5 to 10 years. And we looked at the number of unique cancer patients, cancer survivors, anywhere from time of diagnosis to 20 years after their cancer diagnosis, that was seen by one of our oncology providers at any of our sites over an 18-month period from these dates that you see here. These are unique patients, not the number of visits, by our different cancer groups, again, by the interval. And what you see when you look at this is that roughly almost 21,000 patients are 5 to 20 years. In fact, our breast service now has a 10-to-1 follow-up to new patient ratio. The time to get into a new clinician, one of our oncology providers, is growing longer and longer. And so the question that we've asked ourselves is, with value-based care, should we continue following 20,000 5+ year cancer survivors in the cancer center and have difficult getting in new patients? And from a primary care provider, what I would say is, are we doing harm by keeping these patients focused on something that may not be the primary focus of their own healthcare at this point in time? Let me describe that. This is really nice work that Shauna Hudson, Ben Crabtree, and their group did a couple of years ago, published in JAMA Internal Medicine, where they looked at best care practices in primary care, understanding how the primary care physician looked at survivorship. And they came up with 3 factors that emerged. First, there was an absence of a recognized distinct clinical category of survivorship in primary care. Next, they noticed that there is a lack of actionable information to treat this patient population. And then lastly, current information systems are unable to support survivorship care. My takeaway for this from the PCP perspective is, I followed Ms. Jones for 15 years. She has hypercholesterolemia, hypertension, history of breast cancer, and is worried about her job. Moreover, her husband was just diagnosed with heart disease and their youngest son was in an MBA. In other words, cancer survivorship is just one aspect of the bigger picture of both this patient and their family. Let me talk about the potential for harm. This is emerging data where we're understanding what happens when we have a population of patients that have a high likelihood of survival. In this example, I use breast cancer, but we could just as easily use prostate cancer and indeed our lymphomas, thyroid cancer, testicular cancer, etc. And what we see in this first graph is that the likelihood of death from breast cancer is exceeded by the likelihood of death from multiple other causes, in large part aging. And 7 years after the diagnosis of all stages of breast cancer, a woman with breast cancer is more likely to die of a cardiac event than a woman in the general population that's never had cancer. And in fact, the primary competing risk for this woman long-term is the risk of cardiovascular disease. and not her breast cancer because of the advances in cancer therapy. And this is not because of the things that we do with our cancer therapy, but instead what we see is that these women often have multiple comorbidities, hypertension, lipid abnormalities, or diabetes. So what happens when we focus so closely on the cancer and giving our cancer care to what we see here with adherence to medications for comorbidities. This is work from Group Health, where they looked at the likelihood of a woman staying on her statin therapy before and after the diagnosis of breast cancer. And what they saw is that from the time of diagnosis to treatment, there's a drop-off in adherence that really naters around 2 years after diagnosis, and even by 3 years, only half of women are adherent to their life-saving statin therapy that they're on. Again, contributing to their cardiovascular risk, not because of the things that we did, but because of the things that we did not do. They noticed, and what we've noticed in other studies is that there was improved adherence that was associated with comorbidity management by a primary care provider. So when we think about comorbidities and their importance, hypertension is a major driver. We now have multiple studies that have looked at hypertension either before, during, or after cancer therapy, and recognizing it is a key risk factor for the development of cardiovascular disease in cancer survivors treated with cardiotoxic therapy. And that's not surprising. Here you have this incredible cytokine storm that's going on. We come in with our cancer, and then we say, you know, Ms. Jones, we really need to focus on your cancer care, and yeah, your blood pressure is a little bit elevated, but if we don't need to do anything about it, let's not worry about it. Why don't you just check with your primary care provider and let us know? And the primary care provider sees the patient and says, well, what does your oncologist think? And they say, well, I don't know. They just said check with you. And well, let's not mess anything up. We want to make sure you finish your cancer therapy. All of these studies were done before our most recent American Heart Association, American College of Cardiology guidelines for hypertension. And to date, we have no intervention studies aimed at blood pressure management during or after cancer therapy for an individual with cancer, or even our other comorbidities. This is a nice example of a patient that was referred to me recently by our breast oncology team, seen by a wonderful breast oncologist, radiation oncologist, and surgical oncologist, all three very good doctors, very focused on the patient care. The patient was also followed by a primary care physician outside of the Duke network. She was diagnosed at the age of 42 with invasive ductal carcinoma. She was hormone negative, HER2 positive. She went on docetaxel, carboplatin, and then for her HER2 status, she was treated with pertuzumab and trastuzumab, both known to be cardiotoxic and associated with long-term risk of heart failure. She also had radiation to her right breast. When I saw her, I plotted out all of her blood pressures in the system over time. And what you see is that she essentially lived during this time period largely over 140, over 90, our old measures of what this patient should be. And if you look at some of these blood pressures, you say, wow, there were some that she really looked good. These are simply days she was having a procedure. You see that she had multiple blood pressures all on one day. She had anesthesia and her blood pressure was down. So in general, her trend is elevated throughout, not only during her therapy, but well beyond the therapy. This is an example of a patient seen by one of our primary care providers within the Duke system. Patient had CLL, was on ibrutinib, and you see this very nice note in the system. 51-year-old with a history of favorable risk, treatment naive, CLL, even has the mutations. And then you look at our oncology note and you notice, what do? We are often guilty of cutting and pasting each other's notes. However, nobody mentioned the longstanding history of hypertension of this patient and that this individual was being treated with hydrochlorothiazide, metoprolol, and lisinopril, much less looking at the blood pressure. When the patient started on his ibrutinib, here's the blood pressure trend on there. So the key is getting the right information at the right time to the right person. In this case, letting the primary care provider know, hey, we're putting this patient on ibrutinib. We know that it's associated with elevated blood pressures, but really importantly, about 20% of the time, patients will have atrial fibrillation. We think that their hypertension is a trigger for that. We need to manage it, and you can use whichever medications you want in this case. Indeed, this led us to a funded study that we're starting where we're trying to bring our primary care physicians back into managing blood pressure of patients that are on ongoing therapy. So working with our oncology team, our primary care physicians, and our people behind the background writing our coding for Epic. We use an interface like many of you do that is called Maestro that allows us to make quick changes and not rely on Epic making the changes. And our goal here is to take a Bluetooth blood pressure cuff, as you see here, one made by CardioArm, that shows up in the smartphone with the touch of a button, either using Android or iPhones. And we've already had it where it goes directly into the vital signs section of Epic. And the part that we're working on right now is the automated messaging system, such as, Dr. Jones, your patient, Miss X, has a weekly home blood pressure of 145/92. Target blood pressure for her is less than 135 over less than 85. She is not on any chemotherapy that is known to raise her blood pressure. Please address. For more information on her cancer therapy and risk, see this link. Short message, straight to the point. What the primary care physician wants to know is, please tell me that I'm not going to screw something up. I need to know when I can intervene with my normal approaches. For this study, we're actually working with our primary care network. We have 200, and this is an old slide, 290 now primary care providers, over 40 sites, 7 counties. Everybody is on the same EHR Epic, as I mentioned a moment ago. And we have an underlying research structure for the primary care, what we call a practice-based research network. I'll refer to this again in a couple of slides, or a PBRN. This is just simply showing the different sites on there. So it's a collaborative effort between oncology and primary care, trying to make things a little bit easier and focusing on the importance of comorbidities of the patient and bringing the primary care provider back into patients that are actually on active therapy. Next question is, should we proactively engage the primary care provider as a key member of the cancer team? Nope, they are too busy. Next option is, we are fine without them. And next option is, not a bad idea. I sure am glad as a primary care physician nobody answered the middle option. I can't hear your chuckles, but I hope that you laughed a little with that one. There's the question on there. But importantly, when I talk about primary care providers, remember I'm talking about both physicians and our advanced practice providers, nurse practitioners and physicians assistants. Just like in the oncology space, these providers are incredibly important in primary care also. There's a systematic review published a couple of years ago looking at almost 11,000 primary care physicians. 45% were involved in some aspect during cancer treatment, and this was largely social. And I've gone out to each of our different sites within our network, and I talked to our physicians. And they say, yeah, you know, I know the patients in the hospital, I might stop by and see them, or I'll give them a call, but there's not really an active participation while the patient's on treatment by most primary care providers. There's always the exception. 70 to 80% have some involvement during survivorship, usually farther down the line. Almost all wanting a more active role. Half of them feeling unprepared to manage late effects. And then rarely and inconsistently receiving sufficient information from us from the Cancer Center. I mentioned a moment ago practice-based research networks. This is an effort that's now in about its third decade, started from the Aspen Practice-Based Research Network in Denver. And you see all the different practice-based research networks as identified by the Agency for Health-related Healthcare Research and Quality around the country. And then I'm going to superimpose this with our NCI Community Oncology Research Program, or our NCORE sites, and I'll toggle back and forth between the two. and you'll see that there's opportunities here for collaboration. And indeed, what I mentioned a moment ago is the Duke system has a infrastructure of a PBRN. These are community practices. UNC has the identical thing. In fact, there is a Carolina-wide practice-based research network. And each of you in the room have practice-based research networks in your backyard and investigators within CORE or our NCI comprehensive centers or designated centers that you have the ability to reach out and connect and collaborate. And you can further the work of Deb Mayer and Catherine Alfano as they've described risk-stratified care and described the coordinated strategies that are needed to develop personalized risk-stratified cancer follow-up care, both in patient identification and assignment, defining and developing and implementing care delivery by risk strata, and evaluating the impact on care. Many of you, I hope all of you in the room saw this RFA that came out a little over a week ago, optimizing the management and outcomes for cancer survivors transitioning to follow-up care. There's a number of key points that you have on your slides that I've left with you, but this is a wonderful, wonderful RFA. And I have to say, Paul Jacobson, I saw Paul in the room, and Michelle Malika, and everybody working with the NCI Moonshot Initiative. This is an absolutely wonderful RFA. I hope all of you in the room will be working on this. I know that we will be submitting an application. And with that, I'm going to return to the charge from Deb. And this is really the charge for your day. Where do we need to put our efforts to move the field forward? I'll say that we've made much progress since the 2005 Institute of Medicine. It's an exciting time of research. I think that much progress has been achieved. Next bullet is, does survivorship care need to be distinctively different from follow-up care? And I think the RFA in part acts on that. And I think that we actually have to have primary care providers involved the entire time so that there's not this quote-unquote transition. The next bullet is, how do we change the culture to integrate survivorship care into practice? Do we need to conduct multi-level interventions to move the field forward? The RFA is certainly calling for multi-level interventions. I think that's the only way to move forward in a positive fashion. And then lastly, she's asked me to be provocative, and I hope even from a distance that I've been able to achieve that. And you're hearing in the background, they're getting set up for our breakfast for our meeting. So I apologize for any of the background noise. And in summary, I'm the eternal optimist, and I look at things as being probably 3/4 full. And I think that we've made much progress, and the funding from NCI and from NIH in general and from other agencies, I think, has really led the way in this area. There are many attributes for culture change. Those of us that have been involved in this area for more than a couple of decades can remember giving talks to survivorship audiences that might have an audience member of 1 or 2. And so now we have a true capacity within our research infrastructure. Think of the continuum and not just of the phase. Think of the patient before they're diagnosed with their cancer, what their needs were, the detection methods that were used, whether it's screen detected or whether they presented with symptoms, and what happened with them beyond the time period of their cancer therapy. I hope when you go back to your institutions, you'll make a friend and invite a PCP to your table and have breakfast or a cup of coffee. The agenda for the meeting, I really do wish I was there. This is a great agenda that's covering the major topics that I think we need to tackle with on there. And so with that, I'll say thank you so much. And I'll lead with my last question. Are you ready to make a difference in our patients' lives? Your responses are, nope, I'm too busy. We can't, it's just too hard. Or let's go. And I will activate that.
Thank you very much for this keynote. And I wonder, even though they're just setting up for breakfast, do you have maybe 10 minutes that we could have some Q&A if people have questions?
You bet. We have as much time as you need, so don't you worry. We're good. Our actual meeting doesn't start here for a while, so they're just setting up, so you might hear a little bit of background noise.
Wonderful.
And I'll leave for those that I do or do not know. Here's my email message, and as many of you know, I always like to leave with a picture that's of our outdoor beauty. So go ahead, Trish, I'm sorry.
Thank you. No, no problem. So I want everybody in the room to know that you've got a mic at your table, so you'll press the button if you'd like to speak so that we can all hear you. And is there anybody that has a question or a comment that you'd like to make? It could be that our charge is so clear that we really are ready to go. Okay, we have one. Yes, go ahead. And here's your, and it's you can pick it up and move it around the table.
Hi, Kevin. It's Julia. It's just such a treat to have you with us, and I'm sorry you're not here physically, but your picture is large on the wall here. So, just so you know. So, quick question for you as a primary care provider. One of the big challenges I think everybody is facing in this arena is getting our oncology colleagues to let their patients go. So when you showed those figures at Duke, I just held my breath. I thought, how are they possibly managing that volume? And that's a very disturbing to hear that, 10-to-1 ratio of follow-up patients versus new patients. That's not good for all of us in the boomer generation who are going to just flood your offices soon as new patients. So what are we going to do about that? Do you have insights across your experience or marching orders for us to think about how we're going to solve that problem?
Thanks, Julia. Wonderful question. Great to see you again, and I appreciate all that you have done over the years. I think it's twofold. I'm going to actually start with the end of the question and then go back to end of the answer and then go back to the start. Each of you should find a Kevin Shaw. Kevin Shaw is the Director of Innovation for Duke Primary Care. He's my leverage point. Him and I meet biweekly, thinking through what we can do and what are the needs of our primary care providers across all of our sites and what will work and what won't work. These are busy practices, volume on that. We can't simply say, oh gosh, we need to send all of these patients out. Julia, you and I have been working in this area enough years that we've seen that transition. When I moved to Duke 2 years ago, I started working with our breast group, our leadership, Shelley Wong, Kelly Markham, and Rachel Blitzblau. And early on, they were thinking, we're doing fine. We really need to follow these patients. About a year ago, as they started looking at these numbers and recognizing the ratios and their staff were getting burnt out and their oncologists were getting burnt out, they came saying, okay, we are ready to do the pilots of 100. And so what we've been doing is actually designing pilots of ways that we can actually take patients and transition them safely, high quality, to our primary care providers. Now, as you can imagine, at Duke, no different than at UNC or any of our other institutions or our other community-based centers, about 1/3 to 40% of our patients have a Duke primary care provider. About 1/3 are coming from a distance. And so we're actually working with primary care providers that are Western North Carolina or up in Virginia or even farther away. And then there's that middle group that often don't have a primary care physician. They were diagnosed, they stayed without a primary care physician, they kind of bopped around in the system, and what we're trying to do is get them plugged in. I think the key part from our breast oncologists and our primary care physicians is actually a PR effort that we're working on that says, your primary care, I'm sorry, somebody's, sorry, they're getting set up for our meeting. I apologize. Your primary care provider is important not only later on or before your cancer, but during your cancer therapy. And I think that's the message that we're trying to do on there. I think that primary care providers are just like oncologists, indeed, just like every one of you in the room. It's a bell-shaped curve distribution. There's people on one end that are already doing everything that we want them to. There's people on the other end that regardless of everything we want them to do, they will not accept it. And most people are in that middle area that we just need to be able to give them the tools on there. Our goal in everything we're trying to do is create generalizable, scalable tools, something that can be applied in Kaiser Permanente, that can be applied in Denver, Colorado, that can be applied in Poughkeepsie, New York, regardless of the setting in which somebody is operating, things that work, that blend our primary care providers with our oncologists together. Again, thank you, Julia, for that wonderful question.
Okay. Any other? Yes, and you can use your mic on your table. Just push the button. Hey.
Hey, Kevin, this is Wendy.
Hey, Wendy.
Hey, I love the example of the patient that had the blood pressure cuff, although she was much too glamorous to depict really our typical cancer survivor. The thing here is what I wanted to ask is I think that interface with the primary care physician is key, but did you let the patient in on that so that they could serve as their own advocate as well?
Wonderful question. And first, a disclaimer, that picture was from Cardio Arm's website and not one of our patients yet. Yes, so the messaging goes to the primary care provider with a copy to the oncology team and also a copy to the patient. And part of the enrollment process is emphasizing to the patient that their primary care provider is very important. And I think that it's that forward-facing message, Wendy, that you and I believe in, is it's not just your cancer therapy. Our therapies are really quite good in many areas. I recently lost my mother and my brother-in-law to pancreatic cancer. We're doing miserable in pancreatic cancer, but that's the exception. That's not the rule. Breast cancer, testicular cancer, lymphomas, colorectal cancer, prostate cancer, we do quite well. And so our message to the patient is, you're going to do well in all likelihood, and we're going to do our best to achieve that, but we want your life not just to be cured of the cancer, but long-term longevity. And to be able to do that, we need to do things today, tomorrow, and over the next few years. Wendy, your work in diet and physical activity is so key with that. And as you have done, it's not 5 years after all the damage was done that we need to start thinking about diet and physical activity. It's from day one. Other questions? What I will say while people are thinking is that question that I'm often asked is, well, two questions that I'm asked. One is, are primary care providers really interested in this? And I'll say, yes, they are. I talk with people nationally. I've gone visiting at a number of different healthcare systems. The primary care providers are very interested because these are their patients. They've been following them. They want to do what's right. They want to deliver their best care. The other thing that I hear sometimes is from our Duke colleagues is, Kevin, give me an onco-trained primary care provider. And I'll say, well, there's not such a thing as an onco-trained primary care provider per se. What our goal is to identify somebody within each practice that we can work as a liaison, as a conduit of information. And I think of that individual as being our cancer champion or our viral vector. Once we infect them, we infect the site. And if you look at primary care practices, they practice as a site. There's a selection biases who practices in that group. They have similar traits in the way that they practice, the population that they're reaching out to, et cetera. And so if you are able to identify that one champion in that group, that becomes now the person that is kind of your overarching conduit as you work back and forth and truly two-way, listening to what they're saying as much as what you would like to accomplish or achieve.
Thank you. We do have, I think, 3 questions now. Table 1 first. I don't think we can hear you.
Okay.
There you go.
Hi, good morning, Jamie Goldfarb. How do you account for the emotional aspect of the long-term follow-up with the oncologist for the patient? It's not, for a patient mindset, it can be very difficult to not be seen by your oncologist long-term. No matter how far out you are, there's almost a security blanket aspect to that long-term follow-up with your oncologist, as opposed to just now it's okay for your medical treatment to be done by your primary care physician. So how do you account for the emotional toll on the patients when making long-term care decisions?
Jamie, I love that question. I'm so glad you asked it. I am not an all or nothing person. And I think that there are some patients that benefit by continued follow-up within the oncology space, but not without having their primary care provider still following them. So there can be a co-management. That's at our share care. And I would consider that to person still being a high risk if they have psychosocial needs on there, and that necessitates it. It's a bell-shaped curve distribution. And there's going to be some patients that want to get out of the oncology space very quickly, some that want to hang on, many in the middle that say, tell me what's a right or wrong thing on there. So I think each patient is an individual, and we need to treat them as such. And in those patients, I have absolutely no problem with them continuing with their oncology provider, an important relationship, as long as their non-oncologic care is being addressed. We don't want to save the patient from their breast cancer only to lose them of a cardiac event because of our incorrect messaging to the patient of what's important and what's not. Great question again. Thank you.
And table 2, and then we'll go to table 4.
Hi, Kevin. Melinda Stolle here. A lot of work is within.
Look closer.
A lot of my
Oh,
work.
I can hear you great.
You can hear me good. Under resource settings, so I wonder about the connection between academic cancer centers and then how they work with settings like federally qualified health centers, rural clinics, and how we make that transition, because I find that more difficult, and also that people sort of fall between the cracks.
Again, super question. And Paul Jacobson and Michelle Malika writing up the RFA included that as an important area, equity, and under resource area. I think, first of all, you have the opportunity through the federal health qualified, the FH, I can never get my acronyms right, federally qualified health centers to do some unique things because, again, they're usually on an EHR. We use Lincoln and Durham. It is a true safety net. It's on Epic. We work with them on all of our interventions all across the cancer continuum, cancer screening, referrals, how do we improve upon the referral process on there, as well as survivorship or end-of-life care with that. Duke Cancer Network is a 23-hospital system that is out in the community settings across Virginia, North Carolina, South Carolina, that are often in very poor, under-resourced area. And we've done some interesting work working on diabetes management of our cancer patients and cancer survivors, trying to use whatever technology works for them. And that technology may be paper and pen, it may be a booklet, or it may be a smartphone application. So I think the key thing, as you said, is to recognize everything that we are creating should be transferable into multiple settings, and we understand what are the permutations that need to occur to be able to accomplish that. But that's the key goal that everyone in the room should be heading towards, is making sure that whatever we do is applicable to the full population, not to a subset of population. The last thing that I'll mention is, as I look at across the Duke and I go visit the sites, there's a little town to the west of Durham called Mebane. It's actually spelled M-E-B-A-N-E. I love the way people pronounce and drop letters. The providers there tell me, don't think of our people like Chapel Hill, where they run marathons and they're all vegans. Half of our patients smoke, they're all obese, and you really need to think of those issues on that. So no question about it, is understanding what are the needs within each of our different communities to move forward. Thanks, Melinda.
Thank you.
Hi, Kevin. Karen Besson-Inquist from MD Anderson. So I wanted to ask a little bit about kind of the mindset of the primary care doc with regard to cancer survivorship. I think, you know, at least a few years ago, we were sort of hearing from some of our primary care doctors that, you know, cancer survivors in their practice were relatively rare, and it just wasn't as big a concern as it was for us, right? Not as big a concern for them as it is for us. We think about it all day long. So is that sort of changing in primary care, and is there, you know, you kind of outlined some things that you're doing to sort of make it easier for primary care providers, which I think is great. But I guess part of what I'm asking is, realistically, what proportion of a primary care provider's patient load are cancer survivors? And, you know, are primary care providers really, do they have time to invest in doing the survivorship care and learning, you know, getting more?
Karen, that's so good. You remind me, I should have put one other slide into the slide set. When we looked at what I refer to as our 61,000 slide, that was the number of unique patients seen over that 18-month period by a oncology provider. We've taken that and looked at all 40 of our primary care sites and overlaid that, and we've looked at the numbers by the cancer group, by the interval off of cancer for each individual. And what we've found is that there are actually a lot more cancer survivors than people were recognizing. Duke South Durham is one of our busier sites. They have about 8 FTEs, about 10 providers forming 8 FTEs. They have 782 of those survivors from that 61,000 across groups. And as you would imagine, a large number of breast and prostate, but even of different areas with that. That actually led to what our CLL group reached out to me to do. Our CLL group, chronic lymphocytic leukemia, they were saying, you know what, we're doing really well with patients that have advanced disease or symptomatic disease that we put on monotherapy with ibrutinib. And what we're recognizing is that they then have a second cancer that could have been diagnosed with typical screening, prostate cancer, something like that, or they have their AFib, and we could have controlled that if somebody was watching over their blood pressure. And they actually asked us to reach out and create clinical pathways. So we even look at CLL, which is the less common cancer, across all of those sites. And again, you would be surprised that each of those sites has a few patients. And if you think of that viral vector analogy that I used a moment ago, identify the one person, the one champion that you can be able to have your conduit. That's the way that we can communicate and share that information back and forth on there. So great question. The other thing that I'll say is that MD Anderson is one of the hubs for our Echo Lab. And Echo Lab, if any of you haven't heard of it, look it up. It started at the University of New Mexico. It's a way of doing teleeducation. They started it with hepatitis C management for providers, primary care providers in rural New Mexico. And now that's kind of gone on steroids and used by multiple people. But it's a wonderful way of, from a distance, educating. And so MD Anderson, through Lou Foxhall, is working with primary care residency programs in Texas and how they can educate the primary care providers at the residency training phase in care of cancer patients and cancer survivors. We're doing the same thing across the cancer continuum. How do you, again, kind of engage this on there? So the bottom line is there's a lot more prevalence than we think of, even with less common cancers when you think in terms of a site with that. For the rare conditions, you simply have to think of what's the one-off. How do I get the right information to the right provider at the right time? Our pediatric cancer survivors, that's about 5 to maybe 10 at the most by the typical primary care provider, and they're all different cancers treated at different times. So in those, you need a different type of intervention to get that information to them. But for breast, prostate, colorectal, for most of our cancers, they have actually enough that they just don't recognize. The last thing, pardon me, that I should have said, what are they managing? Hypertension. Well, they do that every day. They manage their diabetes. They manage their cholesterol problems. They manage depression. They work with family social structure, et cetera. So all of the things that we're studying, that's the rubric of what they already work with in their non-cancer population. And just remind them that they can use the same tools and same strategies with some permutations based upon our information from the Cancer Center to address that patient.
Okay, thank you. We have a hard stop at 9:45, and I know, Paul, you were waiting, so you might be the last question.
Kevin, mine's more of a comment than a question. Thank you for the shout out for the new RFA that was just published. I want to point out I've learned here at NCI it takes a village to write and get an RFA approved, and there are many more people involved throughout the division in conceptualizing that RFA, and also members of the Board of Scientific Advisors. I also want to note a second RFA on improving outcomes for pediatric, adolescent, young adult survivors. It had a March 15th receipt date, but it has another receipt date, I believe, in January of 2020. And Danielle Day and Sandy Mitchell are at this meeting, are the scientific contacts for that. Thank you.
Thank you,
Now,
Paul. We have one last question. We now have one last question, if we could. Is that all right, Kevin?
Sure. And Paul, I certainly acknowledge that village, and we appreciate all you've done. Christopher.
Hi, Kevin. Christopher Eclides. I have a question and a quick comment. I guess my question is, you did a wonderful job of reminding us of both the perspective of primary care and also the person power that can be brought to bear on the survivorship population. And I'm thinking, as I do, about mental health issues. You mentioned depression a moment ago. There's a lot of innovation happening in the primary care world around bringing behavioral health and integrating that. And I'm wondering whether you feel as though both the person power and the perspective of primary care could help us with the mental health issues of our survivors. And my quick comment is I just want to go back to the issue before about patients continuing to need to see their oncologist for reassurance. I'll file this under being provocative. Sometimes what we do to reassure ourselves reassures us in the short term and maintains our anxiety in the long term. And I think we need to learn more about who needs to continue to see oncologists and when that's helpful and when it isn't.
You're so right. I think that there's two aspects. There definitely is a growth in good behavioral care in primary care. It's been a focus area. And again, there's always going to be exceptions, but I think in general there is. But patients having gone through cancer therapy, as you and I know, often have a different take on, it's not just simply an anxiety syndrome, but it's fear what's going to happen next, that sense of uncertainty. I've been struck by lightning once, why not twice? And I think that that's where our expertise at the treating institutions needs to reach out and work. This is a two-way partnership. This is a relationship. And our counselors, social workers, psychologists, psychiatrists need to be part of that as we make that effort. And that's no different if I was talking about the heart and cardiologists that are involved in the cardio-oncology space. I think team sciences is what you're going to be talking about today. That's important, but team care is also important, and who is part of that team, I think, is key, part of that medical home. Great question, Christopher. Again, I appreciate everybody's attention. It's kind of interesting doing this from a distance. I've not had this experience, so I hope it was okay. I hope you didn't count the number of nose hairs I had or wrinkles, and I appreciate being with you.
It's been fantastic. Thank you so much.